I'm a pediatric orthopedic surgeon. I work most of my years in Brazil in a large pediatric orthopedic center. I also did a fellowship on the Alfred I. DuPont in Wilmington, Delaware, and also the Children's Hospital in Seattle. And well, I'm working exclusively with child and adolescent and pediatric and orthopedic problems. Also, I work, I'm the editorial board of Journal Pediatric Orthopedic and Journal of Children Orthopedics. And the last 2 years ago, I moved to here, Dubai. So I work now at King's College Hospital in Dubai. Before my work was in Children's Hospital in South America and Brazil, Little Príncipe Hospital in Curitiba, that is the largest pediatric hospital in Latin America. So we also work there with like many friends. We have 12 pediatric orthopedics at the same hospital. So it's a large service. So I'm very interested, especially hip problems in children. Yeah, that's one of my major interests. Pavlik harness is the gold standard for treatment of DDH in young child 0 to around 6 months of age. We know this method for almost more than 50 years. So it's very well known by the orthopedic surgeons as well for the parents. They know about this treatment. So we know how to manage it, and we know how to deal with some complications that it can have or not so favorable outcomes. I think my 90% of the hips treated with Pavlik harness, they have a good outcome. So it's a very efficient treatment, but of course requires a lot of care. Deal with the family, especially the beginning when we started the application of the Pavlik. It's important, the position. I always tell the patients that it's not the Pavlik that corrects the dysplasia, but the position. So abduction and flexion are really the treatment for DDH. So you have to manage very well that to avoid any complications of it can have. But if you have a good experience and care with the patient, follow closely, I think this success is very high. My experience in the bigger center, pediatric center, was not the same. I think it's very, rare to have cases of AVN. I think that most of the cases of AVN are related with the forceful position, especially the abduction. We should remember that Pavlik harness is a dynamic treatment. So we should not force the position. The position has to be, especially the abduction, occurs after 1 or 2 weeks by the weight of the leg of the child that goes for abduction. If you try to do forceful abduction, I think then you can have a high number of complications like AVN. Another complications linked with the Pavlik harness is when you do too much flexion, and then you have a femoral nerve palsy that we recognize because the child lost the ability to kick, to extend the knee. So, but this is usually temporary complication that with the release of the flexion, we improve the condition. When a child grows, become more strong, and also the motor skills improve, it's difficult to hold in the brace like the Pavlik harness because it's flexible brace. So the child fights against that, and they start to sit. So usually it's difficult. I have tried some kids, even 7, 8 months. Sometimes we start with this treatment. Classically, 6 months to 18 months, the treatment is close reduction. If you are talking about subluxate or dislocated hip, unstable hip, then this is the treatment for most of the kids. I use two criteria. One, as we talk about the age, so a 0 to 6 months Pavlik harness for all types of DDH, all grades. From 6 months to 18 months, close reduction in chassis is the main choice, especially for unstable hips. For stable hips, even brace can be tried, some type of brace can be tried at this age. And for kids that are older than 18 months that has a dislocated hip or subluxated hip, so I prefer to go for open reduction, associated or not with acetabuloplasty. Now, my experience is that if I go for a closed reduction in these kids, after the age of 18 months, I will do the osteotomy, pelvic osteotomy. And for kids older than that, like 3 years old, that has a dislocation grade 3 or 4, sometimes you have to associate the femoral shortening. This is the criteria that you use. Usually this brace at this age, we don't know if it works that well. So I have to think about what is the best for kids that has only hip acetabulodysplasia, but hip is well centered, shantung line is intact. These hips sometimes they can develop for a progression of DDH or sometimes even get better with growth. I think the importance of the GP, especially the pediatrician, is fundamental in all countries because they are they have the first contact with the families, and you have the risk factors that are very important to be recognized. In some places, they are doing screening for all babies that are born with ultrasound. But most of the countries has difficulty with that. So, but all kids that are risk factors as breech presentation, familial history, other alterations as torticollis or very flexible kids, club foot, they should be mandatory to do a screening for DDH. I think that in this case, if it was a GP, if it was a pediatrician, and I have a child that or has any abnormality that I suspect some hip different, some limitation abduction, or has one thing that you have seen is that the pediatrician GP asks for some exam, some image, or ultrasound or X-ray. And that X-ray sometimes, or the image is not normal, but the report is normal. So in this case, I think it's important because that is, I think it's important to have somebody else also to assume the responsibility, because it's like it's a very difficult situation when we have a late diagnosis, something that was not realized by the pediatrician or GP, and then later become that was a DDH, and the parents go to the doctor Google, read that, well, I had the risk factors, why didn't do an exam, why didn't do screening? So this is, I think, a strong message here for who sees the patient, GP or pediatrician that see these patients very often. One worry that you have in cerebral palsy, especially for the orthopedic point of view, especially the kids that spastic dysplasia and has a more severe involvement, is the dislocation hip. When you have the dislocation, sometimes there's just one side. So there is some discussion that should I do some osteotomy, the other side, the same surgery, and the other side that's not affect. So is another, because we know that some hips will develop in the future dislocation the other hip. So we did this study, and we had a series of patients that did just one side. We did a treatment of reduction one side, and 50% of the patients present dislocation in the future. So my idea today after this study is that I would indicate bilateral, even if we'll have a lateral compromise, because of two reasons. One, that you have at least 50% of chance to need to do operation on the other side, but also because surgery on one side makes very asymmetrical. One leg will become short, will become the tight will become short, and the part is very asymmetrical for the parents to see that, and sometimes also for the posture of the child. So after this study, I changed my mind. So I do a bilateral correction when you have any unilateral dislocation cerebral palsy. Of course, this is not for VDH. In VDH, we don't do that, but this is a different scenario, different problem that you have in cerebral palsy, then that is my idea today. I think that pediatric orthopedic changes in the way that now we have a super specialized pediatric orthopedics. Some are dedicated only for spine, sports. We have a hands pediatric surgeon. We have like preservation of the hip dislocation. So there is a lot of, I would say, super specialization. And also the technology change. The image is much better that you have now, so we have new opportunities of treatment. And the technology for fixation, for example, the fractures, femoral fractures was a big change, was treated conservatively with casting for many years, traction, and now is much more for operation and full recovery. But another change that I saw was the Ponseti technique came for a club foot that changed dramatically what you have like 30 years ago. But still, the biology is the most important factor. So sometimes the tendency today is to see more technology, biology, the development, the natural history of the orthopedic problems is still very most important for treatment. And the pediatric orthopedics is the base of that, because you can see the nice thing about pediatric orthopedics is that you not relate to just one specialty like knee, one part of the body, and just the patient came, you see, oh, have two knees to treat it. You see the child as a complete entire person, and you treat all kinds of problems that can have. I think this is the beauty of pediatric orthopedics yet. And I believe that we were better now than in the past, but sometimes I feel that sometimes we'll forget some principles that still are the most important when you treat most of the patients. Again, I think that in pediatric orthopedics, we have to deal not only with the patient, but with the parents. So we still, the ability, the skill of the doctor is very important in address the entire situation that you have. If I would start now, what you do in pediatric orthopedics, I think that first we should have a good fellowship, for example, for general pediatric orthopedics first, and then I would maybe do something different, something more specialized that you can treat better this patient with some situations. And also depend on the place that you are, where you're going to work, what are the needs. So if you are starting your career, look around. What the society needs more, what you can do for do a better job, be more useful in that society. And also in pediatric orthopedics is a little bit different, I think, the other specialty, because we have a very important presence in the society. Manage the most of the patients that you see are very simple things and not the complicated ones. And I always say that the good doctor is that they treat well the simple thing. The complicated disease or deformity is complicated for everybody, even for the biggest guy in the field. What differentiates you, what the family will look for you as a reference is that you treat well very simple things. So that's something that the young people, they want to see just the complicated case or the surgery that have to done, but we should not forget that, especially in the field of pediatric orthopedics. If I was not a doctor, probably which I would be, I was a volleyball player. But I would not be a volleyball player. And I would be two areas that I interest: history. I would be like maybe a professor of history, work with history, or a lawyer. I like the laws. I like the study of law. So maybe I would be like, I'll be conservative in my profession, like two old professions, not the new ones that we have, that I don't know what. Today you have some profession that work in some area that I have no idea how is. That wasn't there when I was in university. Well, we don't have that. We didn't have that back then. So I think it would be more traditional, maybe, to do some. I like to study, to read, so that areas would be interesting for me.